Fertility problems, assessment and treatment. It is estimated that infertility affects 1 in 7 heterosexual couples in the UK. Since the original NICE guideline on fertility published in 2004, there has been a small increase in the prevalence of fertility problems and a great proportion of people now seeking help for such problems. The main causes of infertility are unexplained infertility, no identified male or female cause 25%, ovulatory disorders 25%, tubal damage 20%, factors in the male causing infertility 30%, uterine or peritoneal disorders 10%. In about 40% of cases, disorders are found in both the man and the woman. Uterine or endometrial factors. Gamete or embryo defects. Pelvic conditions such as endometriosis may play a role. Given the range of causes of fertility problems, the provision of appropriate investigation is critical. These investigations include semen analysis, assessment of ovulation, tubal damage, uterine abnormalities, and screening for infections such as Chlamydia, Trachomatis, and susceptibility to rubella. Once a diagnosis has been established, treatment falls in 3 main types. Medical treatment to restore fertility, for example, the use of drugs for ovulation induction. Surgical treatment to restore fertility, for example, laparoscopy for ablation of endometriosis. Assisted reproduction techniques, or ART, any treatment that deals with means of conception other than vaginal intercourse. It frequently involves the handling of gametes or embryos. Important issues for discussion. Where there is no known cause for infertility, expected management increases the cumulative chance of successful conception. However, the chance of a live birth, both by natural conception and by using assisted reproductive technology, decline with advancing age because of women's decreasing ovarian reserve. NICE recommends a shorter period of expectant management for women who are 36 years or older. In current IVF practice, it is common to transfer more than one embryo in order to maximize the chance of pregnancy. Further research is needed to assess the efficacy of adjuvant luteal phase support treatments such as low-dose aspirin, heparin, prednisol, immunoglobulins, and/or fat emulsions. Women need to be reassured that it is safe to undergo ovulation induction and ovarian stimulation, and that these interventions will not lead to significant long-term health issues, especially ovarian malignancy. Both IVF and ICSI involve manipulation of egg and sperm in the laboratory, with impacts on the development of the subsequent embryo. Principles of care. Providing information, couples who experience problems in conceiving should be seen together because both partners are affected by decisions surrounding investigation and treatment. People should have the opportunity to make informed decisions regarding their care and treatment via access to evidence-based information. Information regarding care and treatment options should be provided in a form that is accessible to people who have additional needs, such as people with physical, cognitive, or sensory disabilities, and the people who do not speak or read English. Psychological effects of fertility problems. When couples have fertility problems, both partners should be informed that stress in the male and/or female partner can affect the couple's relationship and is likely to reduce libido and frequency of intercourse which can contribute to the fertility problems. It is helpful to contact a fertility support group. Counseling should be offered before, during, and after investigation and treatment, irrespective of the outcome of these procedures. Counseling should be provided by someone who is not directly involved in the management of the individual's and/or couple's fertility problems. Journalist and specialist care. People who experience fertility problems should be treated by a specialist team because this is likely to improve the effectiveness and efficacy of treatment and is known to improve people's satisfaction with treatment. Initial advice to people concerned about delays in conception. People who are concerned about their fertility should be informed that over 80% of couples in general population will conceive with 1 year if the woman is aged under 40 years and they do not use contraception and have regular sexual intercourse. Of those who do not conceive in the first year, about half will do so in the second year, cumulative pregnancy rate over 90%. Inform people who are using artificial insemination to conceive and who are concerned about their fertility that over 50% of women aged under 40 years will conceive within 6 cycles of intrauterine insemination. Of those who do not conceive within 6 cycles of intrauterine insemination, about half will do so with a further 6 cycles. Cumulative pregnancy rate over 75%. Inform people who are using artificial insemination to conceive and who are concerned about their fertility that using fresh sperm is associated with higher conception rates than frozen thawed sperm. However, intrauterine insemination, even using frozen thawed sperm, is associated with higher conception rates than with intracervical insemination. Inform people who are concerned about their fertility that female fertility and to a lesser extent male fertility decline with age. Frequency and timing of sexual intercourse or artificial insemination. People who are concerned about their fertility should be informed that vaginal sexual intercourse every 2 to 3 days optimizes the chance of pregnancy. Insemination should be timed around ovulation. Alcohol. Women who are trying to become pregnant should be informed that drinking no more than 1 or 2 units of alcohol once or twice per week and avoiding episodes of intoxication reduces the risk of harming a developing fetus. Men should be informed that alcohol consumption within Department of Health's recommendation of 3 to 4 units per day for men is unlikely to affect their semen quality. Women who smoke should be informed that this is likely to reduce their fertility. Men who smoke should be informed that there is an association between smoking and reduced semen quality, although the impact of this on male fertility is uncertain, and that stopping smoking will improve their general health. People who are concerned about their fertility should be informed that there is no consistent evidence of an association between consumption of caffeinated beverages such as tea, coffee, and colas and infertility problems. Obesity. Women who have a body mass index of 30 or over should be informed that they are likely to take longer to conceive. A woman BMI of 30 or over and who are not ovulating should be informed that losing weight is likely to increase their chance of conception. Low body weight. Women who have a BMI of less than 19 and who have irregular menstruation or are not menstruating should be advised that increasing body weight is likely to improve their chance of conception. Tight underwear. Men should be informed that there is an association between elevated scrotal temperature and reduced semen quality, but that it is uncertain whether wearing loose-fitting underwear improves fertility. Occupation. Some occupations involve exposure to hazards that can reduce male or female fertility, and therefore a specific inquiry about occupation should be made to people who are concerned about their fertility, and appropriate advice should be offered. Prescribed over-the-counter and recreational drug use. A number of prescription over-the-counter and recreational drugs interfere with male and female infertility, and therefore a specific inquiry about these should be made to people who are concerned about their fertility, and appropriate advice should be offered. Complementary therapy. People who are concerned about their fertility should be informed that effectiveness of complementary therapies for fertility problems has not been properly evaluated. Folic acid supplementation. Women intending to become pregnant should be informed that dietary supplementation with folic acid before conception and up to 12 weeks gestation reduces the risk of having a baby with neural tube defects. The recommended dose is 0.4 mg per day. For women who have previously had an infant with a neural tube defect, or who are receiving anti-epileptic medication, or who have diabetes, a higher dose of 5 mg per day is recommended. Defining infertility. People who are concerned about delays in conception should be offered an initial assessment. A specific inquiry about lifestyle and sexual history should be taken to identify people who are less likely to conceive. Offer an initial consultation to discuss the options for attempting conception to people who are unable to or would find it very difficult to have vaginal intercourse. The environment in which investigation of fertility problems take place should enable people to discuss sensitive issues such as sexual abuse. A woman of reproductive age who has not conceived after 1 year of unprotected vaginal sexual intercourse, in the absence of any known cause of infertility, should be offered further clinical assessment and investigation along with her partner. Offer an earlier referral for specialist. Consultation to discuss the options for attempting conception, further assessment and appropriate treatment where the woman is aged 36 years or over, there is a known clinical cause of infertility or a history of predisposing factors for infertility, where anti-cancer treatment is planned that may result in infertility. People who are known to have chronic viral infections such as hepatitis B, C, or HIV should be referred to centers that have appropriate expertise and facilities to provide safe risk-reduced investigation and treatment. Investigation of fertility problems and management strategies. Semen analysis. The result of semen analysis conducted as part of an initial assessment should be compared with the following WHO reference values: semen volume 1.5 milliliter or more, pH 7.2 or more, sperm concentration 15 million spermatozoa per milliliter or more, total sperm number 39 million spermatozoa per ejaculation or more. Total mortality, percentage of progressive mortality and non-progressive mortality. 40% or more motile or 32% or more with progressive mortality. Vitality, 58% or more live spermatozoa. Sperm morphology, percentage of normal forms, 4% or more. Screening for anti-sperm antibodies should not be offered because there is no evidence of effective treatment to improve fertility. If the result of the first semen analysis is abnormal, a repeat confirmatory test should be offered. Repeat confirmatory test should ideally be undertaken 3 months after initial analysis to allow time for the cycle of spermatozoa formation to be completed. However, if a gross spermatozoa deficiency, azoospermia or severe oligospermia azoospermia has been detected, the repeat test should be undertaken as soon as possible. Post-coital testing of cervical mucus. The routine use of post-coital testing of cervical mucus in the investigation of fertility problem is not recommended because it has no predictive value on pregnancy rate. Ovarian reserve testing. Use a woman's age as initial predictor of her overall chance of success through natural conception or within in vitro fertilization. Use one of the following measures to predict likely ovarian response to gonadotrophin stimulation in IVF. Total antral follicle count of less than or equal to 4 for a low response and greater than 16 for a high response. Anti-Mullerian hormone of less than or equal to 5.4 pmol per liter for a low response and greater than or equal to 25 pmol per liter for a high response. Follicle stimulating hormone greater than 8.9 international units per liter for a low response and less than 4 IU per liter for a high response. Don't use any of the following tests individually to predict any outcome of fertility treatment: ovarian volume, ovarian blood flow, inhibin B, estradiol E2. Regularity of menstrual cycles. Women who are concerned about their fertility should be asked about the frequency and regularity of their menstrual cycles. Women with regular monthly menstrual cycles should be informed that they are likely to be ovulating. Women should be offered a blood test to measure serum progesterone in the mid-luteal phase of their cycle, day 21 of a 28-day cycle, to confirm ovulation even if they have regular menstrual cycles. Women with prolonged irregular menstrual cycles should be offered a blood test to measure serum progesterone. Depending upon the timing of menstrual periods, this may need to be conducted later in the cycle, for example, day 28 of a 35-day cycle, and repeated weekly thereafter until the next menstrual cycle starts. The use of the basal body temperature charts to confirm ovulation is not recommended. Women with irregular menstrual cycles should be offered a blood test to measure serum gonadotrophins, follicle stimulating hormone, and luteinizing hormone. Prolactin measurement. Women who are concerned about their fertility should not be offered a blood test to measure prolactin. This test should only be offered to women who have an ovulatory disorder. Galactorrhea or a pituitary tumor. Thyroid function tests. Women with possible fertility problems are no more likely than the general population to have thyroid disease, and a routine measurement of thyroid function should not be offered. Estimation of thyroid function should be confined to women with symptoms of thyroid disease. Endometrial biopsy. Women should not be offered an endometrial biopsy. There is no evidence that medical treatment of luteal phase defect improves pregnancy rates. Investigation of suspected tubal and uterine abnormalities. Women who are not known to have comorbidities such as pelvic inflammatory disease, previous ectopic pregnancy, or endometriosis should be offered hysterosalpingography to screen for tubal occlusion. Where appropriate, expertise is available. Screening for tubal occlusion using hysterosalpingography contrast ultrasonography should be considered because it is an effective alternative to hysterosalpingography for women who are not known to have comorbidities. Women who are thought to have comorbidities should be offered laparoscopy and dye so that tubal and other pelvic pathology can be assessed at the same time. Women should not be offered hysteroscopy on its own as part of the initial investigation unless clinically indicated, because the effectiveness of surgical treatment of uterine abnormalities on improving pregnancy rate has not been established. Testing for viral status. People undergoing IVF treatment should be offered testing for HIV, hepatitis B and C, for donor insemination, and refer them to specialist care. Viral transmission. For couples where the man is HIV positive, any decision about fertility management should be the result of discussions between the couple, a fertility specialist, and an HIV specialist. Advise couples where the man is HIV positive that the risk of HIV transmission to the female partner is negligible through unprotected sexual intercourse when all of the following criteria are met. The man is compliant with highly active antiretroviral therapy. The man has had a plasma viral load of less than 50 copies per milliliter for more than 6 months. There are no other infections present. Unprotected intercourse is limited to the time of ovulation. For couples where the man is HIV positive and either he is not compliant with HAART or his plasma viral load is 50 copies per milliliter or greater, offer sperm washing. Inform couples that sperm washing reduces but does not eliminate the risk of HIV transmission. If couples who meet all these criteria still perceive an unacceptable risk of HIV transmission after discussion with their HIV specialist, consider sperm washing. HIV-negative women should not use pre-exposure prophylaxis when all the criteria are met. For partners of people with hepatitis B, offer vaccination before starting fertility treatment. Do not offer sperm washing as part of fertility treatment for men with hepatitis B. For couples where the man has hepatitis C, any decision about fertility management should be the result of discussion between the couple, a fertility specialist, and a hepatitis specialist. Advise couples who want to conceive and where the man has hepatitis C, the risk of transmission through unprotected sexual intercourse is thought to be low. Susceptibility to rubella. Women who are concerned about their fertility should be offered testing for their rubella status so that those who are susceptible to rubella can be offered vaccination. Women who are susceptible to rubella should be offered vaccination and advised not to become pregnant for at least 1 month following vaccination. Cervical cancer screening. To avoid delay in fertility treatment, a specific inquiry about the timing and result of most recent cervical smear tests should be made to women who are concerned about their fertility. Screening for Chlamydia trachomatis. Before undergoing uterine instrumentation, women should be offered screening for Chlamydia trachomatis using an appropriately sensitive technique. If the result of a test for Chlamydia trachomatis is positive, women and their sexual partners should be referred for appropriate management with treatment and contact tracing. Prophylactic antibiotics should be considered before uterine instrumentation if screening has not been carried out.